Hi, everyone. I'm Michelle Tennant Nicholson, international publicist. I'm also the vice chair of the Henderson County East Flat Rock Precinct, and I am delighted to bring a healthcare conversation. This is my pet project, howtobeaprecinctleader.org, and I created it so that we would have some more messaging and training so that we had really in-depth conversation with voters in our precincts. And today, from Healthcare for All, I have Marcia Fretwell and Dr. Ellen Kazmarek. Welcome.
Thank you.
Thank you.
We appreciate this opportunity. Marcia is also a physician.
Oh, I didn't know that. So
yes,
both doctors. Oh,
yes, we are.
Oh, wonderful. So hearing from two doctors, tell us, in fact, we just went canvassing last week, and there was one household. That's what they really wanted. They were a young couple, and they were really burdened with healthcare costs, and that was really on their minds. So from your perspective as both physicians and also proponents of Healthcare for All, can you tell us what kind of conversation should we be having with voters at this point?
I think the really important thing to remember is that there are two key takeaway points that your precinct leaders need to keep in mind. The first is to understand what Medicare for All means, and the second is to understand how it's financed and why it would save the country and our fellow countrymen money.
Okay.
So if you're okay, what I'm going to do is I'm going to just explain a little bit about what the Medicare for All means, and then Marcia was going to talk about the financing piece.
That'd be great. Yeah, that sounds great.
Questions after that. So, so what does Medicare for All mean? What we're really working towards is healthcare for everyone that's publicly funded but privately delivered. Public funding means that the government creates a nonprofit agency that then finances the care and pays for it. The delivery of care would continue to be private, which means that you remain in control of your choice of physician, of doctor, of hospital. There's no out-of-network concern that we hear so much about now. You would have eliminated copays and deductibles, and essentially you're in the driver's seat. So the other things to remember are that Medicare for All is also called other names. It's called Healthcare for All. It can be called a single-payer health plan. That's kind of it in a nutshell from my perspective with what they need to understand about how the system would look different from what we have now. Right now, we are privately funded with some public funding as well. So it's a blend, which relies heavily on private insurances.
Okay. Marcia,
and as we move on to financing, it's actually the involvement of these private for-profit health insurance companies, which have actually driven up the cost. And it's by removing them from the equation and moving to a public or quasi-public agency that's going to manage the financing. Currently, the for-profit system has an administrative cost of almost 20%. So 20 cents on every dollar is actually going back to the insurance company for salaries, for marketing and sales, and only 80 cents is going to direct care. The example that exists now is Medicare. Their administrative costs today are only 3%, which means that 97 cents is going to doctors and hospitals and only 3% going back to the agency. So there's the difference. We're going to have that 17% difference of the whole cost of healthcare going back into delivering direct care versus going back to the insurance companies to pay their costs and expenses. So the current system has very high administrative costs. We're going to move to a Medicare-like model, which has already demonstrated effectively low administrative costs. That cost saving is going to be applied to expanding coverage to everybody in the country. Okay. A second, okay, question?
Well, I'll just wait. I'll wait to ask the questions after you've talked about the financing.
The other thing about bringing everybody into one healthcare system, that gives that system increased, we use the word leverage, or you could use power, to negotiate costs. And a good example is the VA system has negotiated drug costs with the pharmaceutical companies and are paying 42% less than what Medicare is paying. If in fact we bring everybody in, I call it the corral, then that public, quasi-public organization will have the leverage to negotiate pharmaceutical costs, big problem today with everyone. They can negotiate hospital costs, and they can negotiate medical device costs. So there are two main points. We're going to reduce administrative costs, use that money for direct care, and bringing everyone into the corral gives that organization the leverage to negotiate reduced costs.
One of the things I want to bring up that Marcia touched on was the VA system. People, and you've probably heard this, that people are so opposed to a socialized system of medicine.
That was my question. Yeah, that was my primary question, because socialism inside a capitalistic culture is a dirty word. So,
no kidding.
Right. So
Yeah.
then for those just playing devil's advocate, sounds like another monopoly.
So here's the story. In our own system, the VA is a nationalized health system. The federal government owns all of the hospitals and delivers all of the care to veterans, and they also finance it. So when those two things are married to each other, the financing as well as the delivery, that's when you have a nationalized system, which is the definition of what the VA is now. So when we're looking at socialized medicine, we already have it in place. That is not what we're talking about when we're looking at a Medicare for All system. We're looking at public funding, privately delivered care.
And remember, the existing Medicare system is already a single payer,
Exactly.
publicly funded,
Right.
privately delivered system. So we have an example functioning within our country. It also functions within Canada. Taipei or Taiwan just recently looked across the world to find what kind of healthcare system they wanted to bring to their island, and they chose the United States Medicare system and just wholesale brought it to Taiwan and
applied it to all of their citizens. The thing to remember too, when we're talking about Medicare for All, it's really an important inclusion point, that when we're talking all, you get a card when you're born that entitles you to care through your life.
That brings up one more cost saving that I want to talk about, where we're going to get the cost. When people don't have adequate access to either insurance, or they're underinsured, or they're paying very high copays, which that young couple probably is paying under the name of health insurance, they delay care. And when people delay care, when they finally show up at the hospital, they're much sicker. And in fact, it costs a lot more money to bring them back to a healthy situation. So one of the real cost savers that's a hidden is by covering everybody, delivering primary preventative wellness-like care to everyone, we're going to have fewer sick people in the United States than we have right now. We have actually, they've done studies looking at what countries delay care the most. And the United States citizens delay care more than any other citizen in the developed countries.
So one of the things that Marcia and I are both geriatricians, which means that we've cared for people 65 and over for our entire medical careers. So what I call the Medicare card is the golden ticket. It's like Willy Wonka in the Chocolate Factory finding his golden ticket, because people delay their health care until they have the golden ticket of Medicare. Why not give everybody that peace of mind by extending it to everybody in this country?
Okay, so by and large, I think for most of our precinct leaders, if you wanted to get the nitty-gritty of what we're talking about around healthcare for all, that's pretty much it. I'm going to continue in the video to have a conversation, because I want to ask a little bit about the differences between what you all see with our Medicare system and our VA system. But before you answer, I want you to know that You're speaking to, I guess I'm getting a little blurry. Let me just like put that in there. It moves on its own. So, so my husband and I, so one of the things that is hard for people to wrap their head around is I'm not, I'm 49, so I don't really like grasp Medicare, other than what happened to my father, and he died in 2004. He was a veteran. He also worked as a nurse for the Veterans Administration Hospital.
Wow. Mm-hmm.
So I saw it from both sides, and my father was never happy. So he was never happy with the Veterans Administration Hospital, but he just didn't complain. It wasn't like one of those, he just kind of took it. So what I'm left with as a military brat is that we've got a broken system. So whether it's Medicare or the Veterans Administration Hospital, because I've only heard my parents complain about it. And so what is the difference between the two? And also, let me just add one more thing. The next conversation I want to have is our current healthcare system, because my healthcare as a successful businesswoman, my healthcare rates are higher than my mortgages.
Yes,
Absolutely.
yes. And if in fact you get sick, you may still find out that you don't have the coverage that you think you have.
Exactly.
Okay, even though you're expending, that's another set of numbers I could go through. But the big thing, let me just come in with my own experience in my practice.
Please.
First of all, my practice was entirely Medicare, which meant 80% of my income was from a single payer. I never had, but when you're in Medicare, patients shop around to find which geriatrician or which internist actually takes care of them in a way that makes them happy. And that's the definition of private delivery of healthcare, is that you keep choice at the local level very much open, and people are free to move from doctor to doctor if they don't like. In the VA system, as your father found out, there was a limited choice of practitioners.
That was the main reason, yes. And that's ultimately, by the way, what caused him to die as primary care physician. I, of course, was like, I think it's malpractice, and he, as a nurse, said people are human, please do not go after them. He asked me on his deathbed to not sue
so sorry.
the primary care physician. But it leaves me with like, this is the state of our health care, and we feel lost. So what about our current, but Republicans and Democrats having a conversation, it doesn't sound, like, where does healthcare for all fit inside the Democrat platform, the Republican platform?
So actually, I'm not sure if you can see this, if I hold it up for you.
If you hold it still, hold it still, we could, your webcam would actually focus on it, but you're moving it. So, okay. Now speak so that your camera goes to you instead of me. You have to say something, Ellen.
Oh, sorry about that. So this is Physicians for a National Health Program. We are our chapter of that kind of mothership program, which is national.
Okay.
So they have put out this, and there's a little bit more to it. Essentially, what's happened over the course of the past year and a half has been that there have been a lot of wannabe programs that have been touting that they're Medicare for all, but they've been what we call incremental programs. So by an incremental program, what we mean is that they still allow the insurance companies to have a whole lot of buy-in and say-so. What we're advocating as a group through both Medicare for All, Healthcare for All, WNC, and our mothership, the Physicians for a National Health Program, is to remove the insurance companies from having the big say, because clearly they're the ones that are benefiting and profiting. As Marsha already alluded to, they make about between 20 and 30 cents off of every healthcare dollar that we spend for their administrative costs and for everything else. So where do we stand with that? The unfortunate part is that when you play partisan politics, which is what's happening so often now, you get caught up in the detail of it. So a lot of the partisan politics are around who's lobbying the most congressmen the most. And it's the insurance companies and the pharmaceutical companies who are heavy lobbyists for everybody's vote. So we kind of, what we're looking at is taking a stand back from the politics and looking at what really should happen. And the good news is, in our area, the Medicare for All has been embraced by the two, the District 10 and District 11 candidates for the House of Representatives. Both Philip Price and David Wilson Brown have embraced a Medicare for All stance.
Okay, so what we can do is, as precinct leaders, is have conversations with these voters that actually say, choose the candidates that really support health care for all, which models a Medicare program that we get at birth versus at the age of 65. That's the takeaway.
Absolutely. Lovely. Well said.
One additional point I'll make, and we would be prepared to come talk to your precinct leaders. The movie,
you're talking to them right now.
Right now, but they should go and download Fix-It, F-I-X-I-T.
Okay.
Healthcare at the tipping point.
Healthcare at the tipping point. It is predominantly the conservative argument for why we need to move to improved, expanded Medicare for all. And it's predominantly a financial, it gets into the value systems, but it's predominantly an economic argument that says what this country should do to control costs and improve care is actually remove the for-profit health insurance companies from the equation, find a nonprofit, create a nonprofit organization to manage the finances, and leave the private delivery system in place as it currently exists. The joke that I love the most is that the conservatives, the Republicans, would end the whole argument with the Democrats if they embraced expanded Medicare for all.
Absolutely.
And it is a conservative, financially sound argument. It's so I just want to, and Fix-It gives it very clearly.
You know, and actually, and if you'll remember, there's the report that came out that the Koch brothers had financed. It came out in the beginning of August, which was supposed to show that, the model that Bernie Sanders had proposed was going to cost the country, gazillions more dollars, actually came out showing that the country would stand to save $2 trillion over 10 years in healthcare costs because of the savings that we would have from eliminating a lot of the waste that goes into the healthcare system right now. So it's, and again, Warren Buffett, who doesn't listen to Warren Buffett that's in a business arena? He's saying that our healthcare costs are the things that are keeping us from being competitive in the world marketplace now. I mean, that's a powerful statement from a powerful man.
And that comes out in the Fix-It movie very clearly too. Also, the Fix-It movie does a nice description of the Canadian model, which answers a lot of questions that people have about the quote-unquote effect of socializing medicine.
What do you say to people in the closing of our video, the final, final things that you want precinct leaders to know? Well, I just am personally curious what you say when people have an aversion to the word socialism. Like that's kind of like a bad word right now, especially. What do you say?
The first thing you ask them is why. Why is socialism such a word that carries such negative connotations for you, or however you phrase it?
I think that a lot of my farmers and rural people in my precinct would say, because it's really expensive and ultimately then we'll never be able to pay the Chinese back.
And that's why we are focusing on the financial argument against our existing system. It is bankrupting the country. It is making us non-competitive with China. One of the really wonderful scenes in Fix-It is a Canadian business owner. Who says, I get all of my materials in the United States. I sell all my products in the United States. I'd love to move my factory to the United States. I cannot afford $1.5 million that I would have to pay in health insurance costs for my employees. You know, we are dampening down entrepreneurism in this country. So as I said, it's really predominantly a conservative model. One last point as a physician, talking about, can you exclude the social issues when you're talking about medical illness? And the answer is absolutely not. It's a phenomenon called the social determinants of health. Mm-hmm. And one of the major problems we have in this country is poor people don't have health insurance. So there's a double whammy that poverty itself makes you sick, and then you have less access to the services. So Medicaid is now, which is the services for poor people, are now trying to understand that they need to integrate the social and medical services, or they cannot bring people out of poverty. Right.
So anything for you, Ellen? Anything final words for you, Ellen?
Well, you know, let me go back to the socialism for a minute. So socialism is already in play in this country in the VA. So if any of the farmers, et cetera, have had members who have been cared for in the VA, they've already experienced socialism. Is it a perfect system? No, but that's not what we're talking about here. We're talking about best practices applied to the medical system in the United States, which is not having best practices applied right now.
Yes. Well, you know, on that note, my husband in 2008 was hit head on by a self-declared taxi cab driver. This was before Uber days, and he was on a motorcycle and broke his femur. So he was faced with having surgery in a developing country and was terrified. And he happened to have travel insurance, and they were very wonderful. And they covered 2 airlifts to the city of Lima. And they also paid for me to fly to be there with him. Wow. And stay there for a month.
Wow.
So that travel insurance, we lucked out. His $200 on that insurance paid off. But I want to say that our fear of being in a developing country, in that month that we stayed in Lima, Peru, while he had 5 screws put into his hip, I was present to the care. It was unbelievable care in that hospital, in that the food that he was given, the care that he was given. And remember, my father had just passed in 2004. So I was in and out of hospitals in 2004 with my father, and then in and out of hospitals with my husband in 2008 in a developing country. So I got to see firsthand the differences in care. And I would tell you what, I would much rather be in Lima, Peru and have surgery than be in Louisville, Kentucky and have surgery.
I'm telling
you, it was a nightmare.
We've been brainwashed. We've been brainwashed in this country to believe that we have the penultimate in healthcare. We certainly have cutting edge technology, but in terms of healthcare access and delivery, not so much.
Yeah, what I saw for my father's, you know, one of the things that broke down was so it's so funny that, you know, we're talking about a single payer system, but it was also because as a project, you know, someone who I basically project manage, right, as campaigns and different things, I kept asking for the project manager. I was like, I don't want to speak to like the lung guy and the, you know, this guy and that guy and the throat guy, and everybody's so disjointed. Who is the one person in charge over my father's health?
Yeah.
And they couldn't give it to me. They're like, oh no, we specialize and we do all this. Yeah. And I was like, I don't understand our system. And then to deal with the bills that come from, it's so disjointed. And so, but that's a whole other.
Well, but it's a very important thing. I started my own practice because they told me I could only spend 10 minutes with each of my patients if I went and worked for a group practice. And I said, I can't get an older person on the table in 10 minutes, much less do it. So I kept my own practice, kept a half an hour visits, and was able to be in the hospital every time one of my patients was in the hospital. And I was that person who held all those pieces together. And what we've done is we've revved up the volume of family medicine and primary care to the degree that they're really not able to produce that, provide that comprehensive, trusting relationship that holds it all together. My hope is that we will be able to go back to that, and we'll be able to look at the whole system and say, what have we missed? And one of the things we've missed is trusting long-term relationships, which would make the quality of the care better.
That's one of the things that we never even hit on was, the physician's portion of this and how do they feel, because there's been a lot of attrition in the physician world because of all of the requirements of the insurance companies for us. So
here's a question that we're probably going to get is should we keep Obamacare, fix it? Is it fixable, or do we need a completely new system?
It needs to be. He was trying to just crack the door open to open the way for a Medicare for all system. He really just, he knew that he could, that's my opinion. And at this point, there's really no going back because the insurance companies have just kind of hammered away at it,
But the one good thing that it demonstrated, it gave a whole group of individuals access to insurance for the first time in their lives
that they won't give up now.
And now they don't want to give it up.
Right.
And I don't blame them.
Right.
They shouldn't have to give it up.
Right.
So that was all about trying to create universal coverage.
Right.
Okay, that's what Obamacare was about. And they didn't get universal coverage, but they got it much higher than what existed before it was put in place. And that has created the voters who are now aware enough that they really want health insurance. And what is it now? 80% of people.
Oh yeah, are in favor of having continuing a level of health care insurance. Yeah, so it's.
Well, I'm sorry.
You can't put the genie back in the bottle now. Just saying.
Gotcha. Okay. Well, so we're gonna. I've got a call even coming in. So thank you so much for being with us today. And
thank you.
I really appreciate these insights. They were really, really wonderful.
Get back to us if you need more help.
Yes, we're here to do whatever we can.
Take care.
Thank you.
Thank you. Bye-bye.